only gold standard was the high ligation and stripping for the treatment of superficial venous insufficiency. And we have to recognize that all along the 20th century, there was pretty no innovation for the treatment of the superficial venous insufficiency. But approaching the new millennium, everything began to change with a maelstrom of innovative techniques such as the radiofrequency laser ablation, the foam, the steam, the mechanochemical ablation, and more recently the glue. These techniques have in common to be minimally invasive by endovenous treatment with a percutaneous access. Among a consistent number of RCT evaluating these techniques, the one of Rasmussen reported similar midterm results with less side effects in favor of the endovenous techniques over the traditional stripping and surgery of varicose veins. Straight and right, since 2011, the American guidelines gave to the endothermal ablation a higher grade of recommendation, followed by the European guidelines, in preference to surgery for the endothermal ablation. That was a disruption for the treatment of varicose veins, which was performed so far. And this disruption is illustrated in these two figures. Looking at the countries in which the endothermal ablation are covered by the insurance, you can see that the stripping, represented in green in the US and in the Netherlands, has practically disappeared. It looks that we are going to a very imminent funeral of the varicose veins treatment by surgery. But is it really a true disruption? Is it a calling into question of the paradigms? Or is it a superficial revolution, a partial revolution? Beyond this technological innovation, what was really new in this evolution? First of all, the first change, in my opinion, was about the high ligation. The high ligation is a cornerstone of the traditional treatment. And you know that during the endothermal and the endovenous ablation in general, there is no performance of high ligation. And all studies showed that you get an absence of reflux at the junction up to 98%, which means that you can get an abolition at the junction despite the absence of high ligation. The second major change was about the saphenous removal, which is also a cornerstone of the traditional treatment. The midterm results in the study published showed that the frequency of the clinical varicose vein recurrence, which is represented in blue, was at least the double of the frequency of the persistence of reflux in the saphenous vein. That means that at least 50% of the clinical varicose vein recurrence appeared despite the abolition of the saphenous reflux after an endothermal ablation properly performed. Therefore, we have got two very big news beyond the technological innovation. We got that high ligation is not necessary, and we've got that saphenous removal is not essential. Without these two cornerstones, the dogma of the traditional treatment collapsed. And this collapse should lead us to call into question the descending evolution, which is the basis of the traditional treatment by stripping and ligation, but also for the endothermal ablation and the endovenous technique in general. And we have to think about an alternative theory. This alternative theory is the ascending evolution theory, supported by an increasing number of publications these last years. This theory explains the evolution of the varicose disease by the beginning on the tributaries at the bottom, creating a varicose reservoir with a siphon effect leading to the emergence of a reflux in the saphenous trunk, which evolves uprising to the junction. That was a paradigm shift. for the understanding of the varicose disease, but also for the strategy of treatment, with a new strategy of treatment calling into question the eye ligation and calling into question the systematic saphenous ablation. Concerning the absence of eye ligation, we have reported our experience of stripping, surgical stripping, without eye ligation. We put a ligation at 2 centimeters of the junction, leaving a stump, like we do when we are performing endovenous treatment. And the results showed very similar things than after endovenous ablation, with an abolition of the reflux at the junction in 98.2%, with a very low rate of inguinal neovascularization, which means that the neovascularization is not only because of the surgical approach, but also because you suppress the drainage of the pelvic and the superficial abdominal venous system. And the rate of varicose recurrence was really decent. Paolo Casoni has also reported and published a RCT comparing stripping with and without eye ligation, and he found a superiority of the absence of eye ligation at 4 years of follow-up for the clinical varicose vein recurrence. A new strategy of treatment is also calling into question the systematic saphenous ablation with the saphenous preservation, and we have described this saphenous preservation through the ASVAL method. The ASVAL is based on this ascending evolution, which enables you to limit the treatment to the tributaries in order to improve the saphenous hemodynamics and the symptoms, because in this concept, the varicose veins are at the origin of the hemodynamic trouble and not the opposite. We observe such improvement at 4 years of follow-up with an abolition of the saphenous reflux and improvement of symptoms in a very significant proportion, and with a significant reduction of the GSV diameter. Since this last 5 years, other authors have reported their experience with this approach, and all studies showed, after treatment of the varicose reservoir, a significant abolition or reduction of the saphenous reflux, a reduction of the saphenous diameter, and an improvement of symptoms in pretty all cases. But following this strategy of treatment, this new strategy of treatment, we went one step further, with the question of knowing if the elimination of the saphenous reflux is the main outcome to evaluate a treatment for varicose veins. In this study, we have followed more than 1,000 limbs, and at 5 years, we observe an absence of varicose vein recurrence in 87%, an absence of the need of a redo treatment in 95.5%, while the reflux was abolished in only 2/3 of the cases, which means that a significant proportion of patients had a persisting GSV reflux without clinical significance. Biemans, in this study about ASVAL, reported the same thing and said that phlebectomy probably reduced the total refluxing volume, explaining the clinical and hemodynamic improvements, even in the saphenous reflux persists. We should not focus only on the saphenous reflux, but also take in account the patient's symptoms, because the presence of a reflux does not necessarily correlate with functional impairment or clinical disease. In this study evaluating the effect of micronized purified valvular fraction on the GSV remodeling after ASVAL, the primary endpoint was the volume of the reflux in the GSV, which is not very common in the studies. And we observed at 3 months a dramatic reduction of the GSV reflux volume after ASVAL plus MPFF during 3 months from 5,000 to 600, with an improvement of symptoms for all patients. We are convinced that the volume of the reflux might be the key element explaining the signs and the symptoms in the superficial venous insufficiency. The effects of ASVAL reported in all studies in literature are the reduction of the saphenous reflux plus the reduction of the saphenous diameters, which ends up to a reduction of the volume of the reflux, explaining the improvement of the symptoms and the quality of life even if the saphenous reflux persists. Therefore, the treatment of the varicose tributaries, that we call the reservoir, should be at the center of the treatment. But we should even look beyond what we see nowadays, and we should look beyond this new strategy of treatment. How might be the future for the treatment of the superficial venous insufficiency? There is one direction, in my opinion, in which we should see the treatment of the reservoir by endovenous techniques, because the endovenous techniques have proven their efficiency. For that, we need a directional carrier that will optimize in-vein progression, enabling to deliver an energy all along the tortuous varicose tributaries for a true endovenous tributaries ablation. We have an example with this slalom project, for which there is already an application for patent. The second direction, in my opinion, is the reinforcement of the vein wall by venoactive drugs. There is an increasing number of evidences that these venoactive drugs are efficient. They target the inflammatory cascade of chronic venous insufficiency. They improve the venous hemodynamics. Therefore, our vision for the future for treatment of superficial venous insufficiency is that adding endovenous ablation of the varicose reservoir plus remodeling the saphenous vein by venoactive drugs is changing the strategy from a destructive strategy to a reconstructive approach more in accordance with the vascular surgery philosophy. Thank you very much for your attention.